All right, well, thank you so much for allowing me to present to the panel and hopefully raise some awareness for a disease that certainly is markedly benefited by the use of stem cells and stem cell transplantation in patients, and a disease that, while it can be deadly, is very fixable, and patients can recover and eventually lead normal lives if caught early enough. So amyloidosis is it's actually a cluster of diseases caused by the accumulation of protein within the organs, and where that protein is produced and where it accumulates varies from one type of amyloidosis to the other. But the most common type that patients have is called AL amyloidosis, where there are cells within the bone marrow that grow. It's in a way a malignant or precancerous condition where there's a growth of one clone of cells within the bone marrow, and those cells produce an antibody light chain protein, because that's what those cells were supposed to do before they became malignant. And as those cells multiply and as they secrete that protein flows around through the circulation and then deposits in various organs. And it can deposit in the heart and cause irreversible heart failure. It can deposit in the kidneys and cause kidneys to fail and the need for dialysis. They can deposit in the nerves, so patients sometimes present debilitated, unable to walk, or with severe pain in their nerves that's slow to recover. And finally, it can deposit in the intestines, and some patients present with malnutrition and losing weight, and they're not really sure why. And from that pattern of involvement and in these various organs, it is often not recognized by the physicians caring for people, because it masquerades as so many other different illnesses. Patients present with diarrhea. It's assumed they have some infection, and it doesn't get worked up until a biopsy is done. Patients present with kidney failure, and they assume it's from their diabetes or hypertension and not from this other condition. The same for heart problems. So the most important and critical thing to assist in the care for patients with amyloidosis is to recognize it early. And I think, being a physician, you recall instances in your own practice where you remember a patient that had a condition, and when you see something again, when you see it happen again, it kind of jogs your memory. And then you think about the disease, and once the physicians kind of think about what this disease, then it's a lot easier to kind of make the diagnosis. So the treatment for these so again, finding patients early is key. The problem is if you wait, and I have a young lady like this right now who didn't get discovered until she's quite ill, and she's in a local hospital, having a difficult time with treatment because she was so ill to begin with. So if patients get started on treatment, you can eradicate those cells and eventually eliminate them seemingly completely. And probably the best way of accomplishing that is through a stem cell transplant, autologous stem cell transplant. And that's been basically considered the standard of care for patients with this condition. So the way that works is patients get their stem cells collected from their bloodstream. They get stored in the liquid nitrogen tank, and then after chemotherapy is given, they get reinfused into their bloodstream, and that can regenerate their bone marrow. And even the very first patients treated over 15 years ago, more than half of them remain alive and free of their disease with continued improvement of their organs and really a return to their normal life, 15 years later. So that's clearly the goal. And so I think what's important for the committee and for what we're trying to do with other physicians and through patient advocates like Mr. York is to have people be aware of the disease, think of the disease, know what the symptoms are, and therefore get diagnosed early so then they can go to a center where they can undergo the stem cell transplant, and which is life-saving. And I don't know if we have questions or you want to, we just move over to Mr. York.
Anybody have questions for Dr. Vescio? Diane.
At what age is it most common?
That's a great question. So the AL form of amyloidosis occurs in a wide variety of ages. It can occur very uncommonly in people in their 30s, but I've seen it all the way up to people 90 years of age. So it encompasses a broad range of ages. It doesn't seem to, fortunately, occur in pediatric patients. There's another type of amyloidosis that's not caused by the growth of cells, and that's more genetic, and that is caused by this protein transthyretin that's made in the liver, and people born with a variant of that develop the similar symptoms, but that's treated differently. That's treated with heart transplants, liver transplants.
Could you just describe the stem cell transplant process itself?
Sure. So the way it occurs is it was discovered 20 years ago, or maybe actually longer than that the cells that can regrow the bone marrow not only are present within the bone marrow, but occasionally they circulate within the bloodstream. There are not so many within the bloodstream, but they're there. So what is done is to coax them out of the bone marrow into the bloodstream with some growth factors, growth factors for stem cells. And by giving these shots, you can kind of stimulate your body to produce more of the hematopoietic or blood stem cells, and also to put them into the circulation. And then there's a new drug that actually makes them come out of the bone marrow better as well. So you give these shots, the stem cells come out into the circulation, and then patients get hooked up to, it looks like a dialysis machine. Their blood goes through this machine, but instead of filtering out the toxins, a centrifuge is done to have the stem cells float to the top of the product, and they get collected into a bag, and then the actual number of stem cells get counted to know that we have enough to regrow the bone marrow. And so once we have enough, the cells are frozen with this compound DMSO, and it keeps them alive but frozen when they get frozen. And then those cells are good potentially forever. And then the patient comes into the hospital and gets the treatment. The treatment is the chemotherapy, but you couldn't give the dose of chemotherapy without the stem cells being put back in, because the chemotherapy, the concept of it is the chemotherapy kills all the blood cells, all the bone marrow cells, including the bad ones, but along with the good ones. And then you put the stem cells back in like a transfusion. And as the old cells die off over the course of a week, the new cells grow back over the course of about a week and a half. So there's a period of time when people need transfusions and other support.
Dr. Lubin.
So my question is, how do you know when you recover the stem cells from the patient that you're not recovering cells that will become amyloid?
So
how do you rid them, or how do you scan for those cells so that you don't infuse cells that can cause the disease again?
That's a good question. And so when that's some of the research that was done collaboratively when I was at UCLA and collaboratively with other centers throughout the country, we would count and measure the abnormal cells that contaminated the product. And there was a device made to purify the stem cells to an even greater amount. But for the multiple myeloma, it turned out that even though that device worked, purified the product, that really the key, it didn't really matter so much if there was a few stragglers in that product. And then oftentimes what we do is we give some treatment first to get the disease under control, to eradicate a lot of the cells, make sure somebody's healthy enough to tolerate the transplant, because not everybody is initially, because that's a strong, aggressive treatment, and then do the transplant, later, and we're less likely to have contaminating cells. And I think at some point the body is capable of kind of fighting off the disease if you eradicate enough of those cells. It just gets overwhelmed if the process is more aggressive as it's built up.
Mr. Julesgaard.
So I assume what you're talking about is a medical procedure.
Correct,
That's
yes.
akin to a blood marrow transplant. And so this is not an approved product, it's not regulated by the FDA, and each laboratory does it in its own set of conditions.
It is a regulated product. It's through the, there's a blood bank organization, and my kind of partner knows this in much more detail than me, and the blood bank personnel do as well. But there is a lot of regulations that are involved with it. There's procedures that are followed. I don't believe it's part of the FDA that does it. It has something to do with the blood banking and pathology, the way they maybe regulate blood products, because this is considered a blood product. It's not manipulated blood product. It's considered a blood type of product.
Dr. Stewart?
Could you say a word about what role CIRM funding has played, if any, in these approaches and the background science?
Well, I think for this particular type of procedure, it's been going on for quite some time, but it keeps advancing as we go along. I don't have all the details of exactly how the CIRM has added to this particular type of treatment, but I know that the whole process of collecting stem cells, trying to grow them, trying to, not only for this disease, but for other diseases, maybe modify those cells to make it either grow the bone marrow back faster, or maybe grow it in a way so you can selectively grow those cells in the bone marrow and after the transplant even further eradicate residual cancer cells. I think that's where the progress is going to be made.
Anne-Marie?
Can you come back a little bit on the genetics? Tell us a little bit more about this and whether this runs in families at times.
So the type of amyloid, there's different types, and that's what makes this whole disease quite confusing. The AL type of amyloidosis is related to a cancer called multiple myeloma, and that's why I treat both of those conditions. There does seem to be a small amount of genetic tendencies in the disease, so that it's estimated that 5 to 10% of people with multiple myeloma and presumably the related condition AL amyloidosis have that develop because of some type of genetic predisposition. And I know at our recent American Society of Hematology meeting, they were discussing, progress being made looking into that to see what genes that can be kind of altered or that people are kind of born with that makes them more likely to develop these conditions. Because in any one cancerous type of proliferation, it would be nice to think there's one mistake in that cancer cell that makes it a cancer cell. Unfortunately, that's too easy. That would be nice, but it's too easy. Instead, it looked like there's 10, 15, 20 mistakes. And so people that are maybe born with some abnormalities in one or two things they're already 2 steps along the way to develop the malignant disease. So that's kind of what's been discovered lately.
Leon?
What are in multiple myeloma, what are the 30-day approximate mortality rates for autologous or allogeneic transplants, bone marrow or stem cell transplants?
So that's where a lot of progress has been made. The risk of mortality for multiple myeloma, which is a cancer of the same cells, but where the protein is not building up in the tissues, and people are in a way healthier going into it, the mortality is 1% in 100 days. So it's not 0, and we still have some people get sick, but most people do survive the experience. The challenge is for amyloidosis, the organs, it's not only getting rid of those abnormal cells, but the organs for many of these patients are not normal anymore. The heart is thickened with this protein. The kidneys aren't working correctly. The intestines aren't working correctly. So the mortality is higher. It can be 2 to 5% to go through the stem cell transplant. And I think where progress can be made, and everybody makes incremental progress, there's been incremental progress in just kind of doing the procedure and giving various medications to treat infections. But if you can make people more aware of the disease, people can come in to be treated when they're less ill, it makes the stem cell transplant procedure safer and actually doable. There are people that I'm not capable or I don't feel it's too risky to do the stem cell transplant procedure on them, and we have to try other ways of treatment.
Are you saying that someone who's had their bone marrow wiped out prior to transplant only has a 1% mortality as part of that procedure?
It's a 1% mortality from the transplant procedure if you have multiple myeloma. If you've had the AL amyloidosis, then the risk used to be 20%. Now it's more like 2 to 5%. And so it's improved, but it still makes us, 5% is still significant, and that makes us wary when we're going, treating patients with this procedure.
You mentioned that one of the main improvements that could be made is the ability to detect this disease earlier in life. Besides this, what would be the other improvement that you would hope for to improve the condition of these patients? What's the next step in research?
Well, I think there are some medications that have been shown to be effective, and the challenge now is well, there's always a challenge to develop even further medications, and I think one of the problems is that amyloidosis is not a common disease, so there's not a great incentive for the pharmaceutical companies to get something approved to treat amyloidosis, and many times when I'm trying to treat patients with this condition, I'm handicapped by the fact that I'm not allowed to treat them for the disease with the same medicines that work for multiple myeloma and in fact are the same disease. But the insurance companies aren't necessarily, it's not approved for that condition, and these medications are expensive. So they don't always allow me 100% of the time to treat patients the way I would like to and think is best. I think that there are new medications. I think one of the keys might be to give medications first, historically, and then allow the patient to hopefully recover, and then do the transplant as a way of doing the final eradication of the disease. And I think that's probably the wave of the future, and that's what's being done more and more in the past 5 years.
Okay, thank you. Thank you, Dr. Vescio. I know you have a plane to catch. We
no
appreciate you staying with us here for this most important presentation, so thank you very
My
much.
pleasure. So it's very nice to meet you all and see this great work being done.